Hello, today I'll be presenting CCR5 delta 32 stem cell transplantation, a case of long-term HIV control. So this presentation involves two case studies. One, the Berlin patient, male, 40 years old, living with HIV on antiretroviral therapy for 10 years, which has prevented the progression to AIDS. And this patient is diagnosed with acute myeloid leukemia, or AML. And patient number 19, who is a male, 53 years old, who's under the same circumstances, living with HIV on antiretroviral therapy and diagnosed with AML. So HIV is a virus which infects our CD4 plus T cells by binding to a CCR5 co-receptor to inject its RNA into our cells. About 1% of the white population confer resistance to this strain of HIV because they have a mutation, a CCR5 delta 32 homozygous mutation, which means 32 base pairs are deleted. And cells don't have the CCR5 receptor present on the cells. So HIV is not able to bind and enter the cells and infect them. So the researchers of these studies were using this to an advantage, where they were doing stem cell transplantation for the acute myeloid leukemia and wanted to see if they used donors with this CCR5 delta 32 mutation, that the patients receiving them, or the recipients, would be resistant to HIV as well. And what they found, first, they confirmed that CCR5, they wanted 100% donor chimerism, and that can be seen in figure 2. So they did PCR of the alleles, and at 200 base pairs, it's the CCR5 positive, and at 168 base pairs, it's the CCR5 homozygous delta 32. And the patient, 61 days after stem cell transplantation, shows the same band at 168 base pairs, meaning 100% donor chimerism of their cells not containing the CCR5 co-receptor. They also found no detectable RNA HIV-1 load in the serum during follow-up periods in both patients. They measured this by DNA and RNA PCRs, and this means that HIV is not replicating in the cells even after antiretroviral therapy had been stopped. So they stopped the therapy for the stem cell transplantation to occur, and HIV is not replicating anymore. They also tested T cell reactivity. So as shown in figure 4, the percent of HIV specific CD8 plus T cells is decreasing as the months after the transplantation are increasing. So GAG, NEF, and POL are HIV proteins. It can be seen that their reactivity is decreasing. They also tested antibodies against specific envelope and capsid proteins of HIV, as shown in figures 5 and 6. So figure 5 is from the Berlin patient, and figure 6 is from number 19 patient. It shows that antibodies against specific GP and P proteins are decreasing as time goes by after transplantation has occurred. The bands are getting lighter compared to a positive and a negative control. The Berlin patient also underwent a rectal biopsy. Just the researchers wanted to confirm that the CD4 plus T cells don't have the CCR5 co-receptor present anymore. And it was confirmed. However, they did find some macrophages with the CCR5 co-receptor still present. And figure 3 just shows the clinical course of myeloid leukemia, HIV, and HIV-1 viremia. So it shows HIV-1 RNA decreases immensely after heart has been stopped and transplantation had occurred, and CD4 plus T cell levels are increasing, which is a good sign because HIV targets CD4 plus T cells, causing patients to have very low levels of them. So in conclusion, figure 7 just shows the process of transplantation. So the patient has these cancerous cells and their regular cells with the CCR5 co-receptor. They undergo chemotherapy and radiation therapy through many drugs, including cyclosporin to prevent graft versus host, and many different immunosuppressants. And step 3 is where this CCR5 delta 32 homozygous donor comes in. So it's shown that the cells don't have the CCR5 co-receptor present. And step 4 is the production of healthy cells, as well as cells that don't contain the CCR5 co-receptor. So stem cells are able to produce any type of cell under their lineage, so they can divide into any type of cell, which are now healthy. So two patients living with HIV diagnosed with AML underwent stem cell transplantation with CCR5 delta 32 homozygous donor cells. There was no sign of HIV rebounding after discontinuation of antiretroviral therapy. There was a continuous decrease of HIV targeting immune cells, 100% donor chimerism of CCR5 delta 32 cells, and no HIV replication. Although there were still CCR5 on the surface of macrophages, as was mentioned previously, the researchers found that there was no HIV DNA present in the tissue, meaning that although the co-receptor for HIV to enter was present, it wasn't being used to infect cells. So I believe that future studies regarding this topic can include gene editing therapies involving CCR5 delta 32 homozygous cells, so possibly editing cells to remove this CCR5 co-receptor from their surface. But I believe that has to involve efficacy and some implications of this study would include the lack of CCR5 delta 32 donors. So as mentioned, only 1% of the white population have this mutation, so it would be difficult to scale this possible cure to a higher level. And keeping in mind HLA matching, which these two patients had undergone with their donors, and host graft responses are important for if future wants to be done.